Good afternoon. I'm Bob Blum, and the director of the Johns Hopkins University Urban Health Institute, and it's my pleasure to welcome you to our winter symposium. A word about how these symposiums function. Dr. Satcher will be giving a presentation. As you can gather by the table that is in front of the room, there are three people who will be reflecting on that presentation and grounding it in our experiences in Baltimore. Pastor Tony Draper, Diane Bell McCoy, and Dean Michael Clagg. I will introduce them in a little bit more detail after Dr. Satcher's presentation and as they are coming to take their place. It is for us a great honor to have Dr. Satcher come. David Satcher's trajectory to today began, as I understand it, when he was quite young and quite sick. And at about the age of 2, his parents were told that it would be unlikely that he would survive because of his illness of whooping cough. And to the blessing not only of his family, but to this country, he did. It is because of those early experiences that he went to Morehouse as an undergraduate, to Case, Western Reserve, for medical school and for his doctorate, and has had an extraordinary and illustrious career since then. As professor, department chair at Morehouse, as president at Meharry University, as the director of the CDC, as the Surgeon General of the United States across 2 administrations appointed by Bill Clinton in 1998 and through 2002. Since that time, he has returned to Morehouse and currently leads the Satcher Health Leadership Institute with a focus on generating the next generation of leaders to address health inequalities in the United States. It is a tremendous honor for us to have you here today, David. Thank you for joining us.
Thank you very much, Bob, for that very kind introduction. I'm delighted to be here. It's an honor to be asked to give this very important lecture. It's been a great day. Had an opportunity to meet with former deans, School of Public Health, and other leaders. Had an opportunity to have lunch with community leaders and a very lively discussion. And more just recently had an opportunity to meet with students. So it's been a great day, and I'm delighted to have had this opportunity to be with you. I bring you greetings from the Morehouse School of Medicine in Atlanta, and especially the Health Leadership Institute there. The whole issue, of course, of disparities in health is something that I have been concerned about for many years, as many of you have. I've had opportunities to contribute to strategies, and I know that we have a long ways to go in this commitment to eliminate disparities in health. But the commitment in and of itself is an important one. What you're committed to does make a difference in how you behave, and sooner or later it leads us to the place where we need to be. We've had some setbacks. Obviously there are about 8 million people now, 8 million more people uninsured than there were in 2000. And in many ways, our healthcare system is leaving out people even who are not uninsured. And we are, I think, closer than we've ever been before to reforming our health system, but we're not there, as you well know. In addition, and just as important, of course, is that with our recent economic downturn, there are many more people, of course, who are unemployed, who are poor, and that, too, has a tremendous impact on health, and a disproportionate impact. So it has an impact on disparities in health. All the more reason, of course, for us to continue to press forward and to provide the leadership that's going to be necessary for us to reach our goals. It is a goal that America can not afford to turn back on any more than we can turn back on our goal of reforming our health system in such a way that it includes everybody and that our health system doesn't punish people for getting sick. Believe it or not, we punish people for getting sick. Through 2007, the leading cause of bankruptcy in this country was people becoming severely ill and being dropped from their insurance or not covered because they lost their job or what have you. I don't think we as a nation, just from an ethical perspective, can any longer afford to live with that kind of system. So we have a lot of challenges, but also a lot of opportunities, I think, to make a difference. I want to say a word about the Satcher Health Leadership Institute, and you have to pardon the photos. That was not my idea. Some of my children say that it looks like a study of aging, but that was not. But be that as it may, I wanted to share our mission. Our mission is, in fact, rooted in our commitment to eliminate disparities in health, but also our belief that, as the Institute of Medicine said in its 1988 report on the future of public health, said the need for leadership in public health is too critical to leave their development to chance alone. The need for leaders in public health, too critical. We can no more just wait and hope that we have the leadership. We have to contribute. For me, that means sharing what we have learned throughout our careers. I tell all of our students and fellows that I'm not an expert in leadership, but I'm a very serious student of leadership, and therefore I like to share what I've learned, the mistakes I have made, and all of those things. So it's a delight to be here. I should say that there are a lot of people here I should recognize. I especially want to recognize Senator Sarbanes and thank him for his leadership. When you spend as much time in Washington and at the CDC as I have, you come to appreciate people like Senator Sarbanes, and so it's great to see you. I should say you come to really appreciate them. All of us appreciate them, but when you see how things get done and who makes them happen. There are two former deans here, but also there's a former director of the CDC, D.A. Henderson, who played a major role in leading the battle against smallpox and has been just a tremendous leader and mentor. And Al Summers, the former dean, is right now a member of the advisory board of the Satcher Health Leadership Institute, and has been a great friend in a lot of ways. A tremendous colleague of mine, Al Noonan, who now is Dean of Public Health at Morgan State, is here. Somewhere, Al is here. There he is, okay. So let me say that we take leadership seriously, and just a few of the things that we believe and we stand for. We believe that leaders respond. We have strategic plans and strategies, but leaders also respond sometimes to the unexpected. We respond to opportunities, to challenges and crises, and we have a lot of those to respond to, but leaders respond. We believe that leadership is a team sport. It's not an individual sport, but a team sport, and building teams is a part of what we have to do. Talking to students about the fact that it's not position dependent. There are a lot of people who have positions that they would like to see themselves in. That's not necessarily leadership, and there are people who lead from whatever positions they're in, And generally, when you're looking for somebody to serve in major leadership roles, you look for somebody who's already leading where they are, who've already taken advantage of every opportunity to lead. And I know that many of you are doing that in this effort to eliminate disparities in health. Effective leadership transforms communities, and a lot of that leadership is in communities, so working together we can transform communities, and there are many ways in which many of our communities need transformation. When we prey on each other, in many cases, we make it unsafe for people to engage in healthy behaviors. We need transformation. We need to make sure everybody has access to opportunities for healthy behavior. Leadership requires a global perspective more and more because we live in a global community. Had the opportunity to work with the World Health Organization on the social determinants of health and to travel all over the world looking at different challenges in this arena and the way in which different countries were approaching the issue of social determinants of health. But we learn a lot when we look at what other people have done, whether we look at what they've done about reforming their health system or how they're approaching the social determinants. So we need to have a global perspective. And finally, from my days of running track or trying, I believe that leadership is like a relay race. The relay was always my favorite race. I ran track at Morehouse, and I was just fascinated with the relay race. Never ran it because the coach knew better. So I watched it, and I always watch it now. And if you watch the Olympics in China, you remember that our 4x100 teams, both the men and the women, lost because they dropped a baton. And that often happens in our society in terms of leadership. When people drop the baton of leadership, we all suffer because of it. On the other hand, leadership is like a relay race because sometimes individuals are disappointed in how much they're able to achieve during their tenure. And what we have to remember is that it's a relay race. Luther Terry released the Surgeon General's report on smoking and health in 1964. And just about every Surgeon General since then, including the three that I released, every Surgeon General has released a report on smoking and health. It was not until 2009 that Congress gave the FDA the authority to regulate tobacco as a drug. Think about that. Luther Terry has been dead a long time, but the benefits of what he did and the fact that there's a relay race being passed from one Surgeon General to the other means that we now have a much better opportunity to regulate tobacco as a drug. One of the most addicting drugs known to man is nicotine. So it's an example, and I say that because I know many of you are struggling. You're struggling in the community or in academia to try to change things. And you may not achieve everything that you would like to during your tenure, but just remember, it's a relay race. And if you advance the baton well enough, and if you pass it smoothly enough to the next person, then it continues to go forward. Well, as Surgeon General, I had this opportunity. I didn't have a lot of money as Surgeon General, but I had this tremendous opportunity to communicate with the American people based on the best available science. And we used those opportunities. We worked with the CDC, we worked with NIH and HRSA and others to pull together this science. And first ever report on mental health we released in December of 1999. And our major recommendation was that we, as a nation, we move toward comprehensive parity of access to mental health services. That was December 1999. And in October 2008, after Congress passed the legislation, President Bush signed the Mental Health Parity Act. Again, it took a lot of people to be involved in pushing this before it became law. With the report we released on overweight and obesity calling attention to this epidemic, it didn't take quite as long for Congress to pass the wellness policy. We released a report in 2001. Congress passed the policy in 2004. I think that means a few things. Number one, I think we're getting better at communications, and especially at communicating about public health science. We need to still get a lot better than we are now. We need to do a better job of influencing policy with science, but it requires a special kind of leadership. But it's an interesting thing. You know, I've been working with the schools since I left office in a program called Action for Healthy Kids. And we're trying to get the schools to return to physical education K through 12 and to model good nutrition. And when Congress passed the wellness policy, they basically said within 2 years, in order for the schools to continue to get money for free breakfast and, and free lunch, they had to have in place a wellness policy. And sure enough, by the end of 2006, 94% of schools in this country had wellness policies. That's the good news, right? The bad news is that they had not implemented them. But also that Congress had not given the money for them to implement them. So we're still struggling with how do we keep our children healthy? How do we avoid the epidemic of overweight and obesity that's going to lead to more diabetes, more cardiovascular disease, more cancer in the future? So we have to keep pressing. There's a lot of leadership needed here as we move forward. I could talk about some of these other reports, but I think you get the picture. Healthy People 2010 had 2 goals. We really wanted the American people to remember these goals. One was a goal that was responding to the fact that we are an aging population. Several CDC reports have pointed out that the fastest growing group of people in America today are people over 80 years of age. And that's really good news. The bad news is that half of the people in this country today over 80 are incapacitated, physically, mentally, or both. And I participated in the Alzheimer's study group, and I hope you've seen that report. There are about 5.3 million Americans today with Alzheimer's disease. We projected that by 2050 there will be over 16 million Americans with Alzheimer's, and whereas we're spending about $150 billion today treating Alzheimer's, by 2050 we'll be spending over $1 trillion a year. So, but that's not as important as the fact that this disease is such a burden for individuals and families, and we're not providing families with the support they need to deal with Alzheimer's and other forms of dementia. So this goal is a really critical goal, which I hope we hold on to in Healthy People 2020. The other goal is the one that we've talked about a lot, and that is the goal of eliminating racial, ethnic, and socioeconomic disparities in health. And it's a very important goal, and I want to talk a little bit about it. I want to begin with the ending. I want you to know at the outset that according to our 2007 report on disparities, disparities in health care quality and access are not getting smaller. And in part, I told you that 8 million more people uninsured. So our health system is not helping here a lot. Progress is being made, but many of the biggest gaps in quality and access have not yet been reduced, if you've been following that. And then finally, the problem of persistent uninsurance is a major barrier to reducing disparities in health. So the health system is not helping, but the health system is not the only issue in disparities in health. It's very important to remember that, especially for those of us in public health. Health system is important, but it's not the only issue. Access to quality health care is basic, but we also have to be concerned about how we deal with genetic risk, how we deal with the environment, physical and especially social. We're learning more and more about the social environment every day, and how we deal with behavior. The estimates are, in most studies, that when you look at the variation in morbidity and mortality, that about 15% of those variations are accounted for by different access to quality health care. Genetics for about 20 to 25% of the variation, environment about 25%, and behavior about 40 to 50%. But that's really only part of the story, because the rest of the story is that the social environment includes the social determinants of health. And what we know now, since our report from WHO, is that poverty, income, safe communities, workplace safety, influence all of these things. In other words, a person who lives in a community that's not safe, that does not have walking trails and safe parks, is much less likely to be out walking or jogging or biking than somebody who lives in a community where it is safe. So the social situation determines that. Education is a major variable in health outcomes. If you look throughout the world, health outcomes relate specifically to education of the population and to income. So we now know that we in public health and medicine cannot operate in isolation. We have to work with others in terms of dealing with the impact of social determinants on health outcomes. And of course, overriding all of that is policy and interventions. We have to have the right policies in place in order to make progress in eliminating disparities in health. We've got to get the right policies in place to support that effort. Well, let me just say briefly what hopefully you already know, that in the major cause of death in this country, cardiovascular disease, there are major disparities. Today, of course, black men have the greatest risks of death from cardiovascular disease, but it is a major cause of death for all groups. Disparities, however, start at the beginning with infant mortality, where African American baby born in this country is 2.5 times as likely to die in the first year of life. An American Indian baby twice as likely. So those are interesting disparities. And I think diabetes, of course, is one of the most interesting, and it's one of the areas where we're seeing the greatest increase because of the obesity epidemic in this country. American Indians are at greatest risk for diabetes. But as you can see, it's one of those problems that's affecting every group, and it's increasing in every group because of the obesity epidemic. It's an interesting challenge that we're faced. In talking with the people in the community luncheon today, sometimes I think we forget the impact of disparities in health. So I gave the example of the study that we did at the Morehouse School of Medicine a few years ago that was published in the Journal of Health Affairs, in which we looked at mortality ratios. And we looked at two groups, African Americans and whites, because those are the only two groups that we have data. We have data on those two groups going back to 1900. We can tell you that in 1900, when the life expectancy in America was 47, it was 49 in whites and 34 in African Americans. By 2000, the life expectancies had obviously increased. It was about 77 among overall and about 72 in African Americans. So we continue to see there's a closing of the gap, but there's still a major gap, such that if we had eliminated disparities in health in the last century, what if we had eliminated disparities in health in the last century? Then in the year 2000 alone, just looking at these two groups, there would have been 83,500 fewer deaths among African Americans. 83,500. And if you look at that and say, well, in the last decade of the last century, that means almost 900,000 what we call excess deaths. And 2.5 million excess uninsured. Not 2.5 million uninsured, many more uninsured, but if it had just been equal, and of course we don't want it to be equally bad, and but if it had been equally bad, African Americans would have 2.5 million more people insured. So I think you get the picture. Disparities in health are serious, and not just because of mortality, but because of unnecessary pain and suffering, and especially what's happening to children all over this country. In social environments, in many cases, that militate against education, militate against hope, which means that we have more and more people ending up in our jails and prisons. We're building more jails and prisons, but we're not stopping the epidemic of violence that relate almost specifically to poverty and other major social problems. So that's the challenge that we face. The points of attack from our perspective include improving access to care, improving the quality of care that people receive, trying to improve lifestyle, environmental quality, physical and social, and having a balanced research agenda. A balanced research agenda. We need a balanced health system. We need a system that balances health promotion, disease prevention, early detection, and universal access to care. That's what hopefully we're going to end up with in health system reform, a balanced health system. But we also need a balanced research agenda. And I know many of you are becoming involved in research in the community. You're developing partnerships in the community. I know about the Brown Fellows. And I think that's what it's going to take. It's going to take that kind of partnership where the research agenda becomes much more balanced in the future than it has been in the past. And we're going to have the data, the information to solve problems that we're not able to solve today. And we're going to have partnerships of the kind that we have not had between academia and community. And that's what the Urban Health Institute is about. When I was Surgeon General and Assistant Secretary for Health, with the urging of Dave Rogers, who had been president of the Robert Johnson Foundation, we funded 3 urban research centers in the country, one in Detroit, one in Seattle, and one in New York, looking at how we could begin to get to the bottom of urban health problems. And then, of course, later on, the CDC funded the REACH program, Racial and Ethnic Approaches to Community Health. So we're beginning to support the kind of research that's going to help us to better target some of these problems. But we need balanced research, and we need to fund it in a balanced fashion. We need to fund public health research and not just basic research and clinical research. And we need to fund all of those, at an ever-increasing level so that we can continue to lead the world in this area. Well, there are a lot of barriers to access. And the worst thing I could do would be to give the impression that the only barrier to access is whether or not you're insured, even though that's critical. But there are people who are uninsured. There are people who are underinsured. There are people who are underserved, even though they're insured. They're underserved because of where they live, or because of the fact that the distribution of health providers do not match the distribution of the population, and because groups are underrepresented in the health professions. And so sometimes they don't speak the language or understand the culture. So being underrepresented in the health field can be a problem. And then some people are just uninspired. In talking with the people today at lunch, the community leaders, very important point about what happens to people when they lose hope. What position does health take when people lose hope about their future? When health becomes a lower priority because they're worrying about their safety or whether they're going to be able to access food. So a lot of people are just uninspired because we have taken hope away from them. And that's the worst thing you can do for anybody, is to rob them of their hope for the future. And we've got to find more ways to continue, especially to inspire children, so that they can believe they have a future. I grew up in a home where neither of my parents finished elementary school, but as somebody was saying to me today, it's amazing how we had hope. It's amazing how in that environment somehow our parents convinced us that we were supposed to make something out of ourselves, as they used to say. They were committed to our education. We have to be committed to our children, starting in the home, in the community, in the government. We have to be committed to our children. Some people are untrusting of the health system, and it's not just about Tuskegee. That's what we talk about most of the time. And that happened, of course. But there are people who have experiences every day that make them untrusting of the health system. And so it's not just about what happened back then. But it was great as Surgeon General. Well, I guess I was director of the CDC, to get President Clinton to apologize for the Tuskegee study and to bring the 9 survivors of the Tuskegee study to the White House. I have a great picture in my office now. But hopefully a lot of lessons came out of that, and we have a better system of research, because we learned from that. And people are uninformed. A person at the luncheon said to me, so many of our people don't read at a level they can understand health information. And my colleague, Richard Carmona, when he was Surgeon General, released a report on health illiteracy, saying that 90 million Americans are illiterate when it comes to health. They can't read at the level to understand health instruction. So these are all challenges. I'm just putting these out here because I know you guys are going to solve them. So I'm just saying, here it is. And I know you're going to become leaders and help solve these problems. And we're going to move toward eliminating disparities in health. If I didn't think you could solve them, I wouldn't be putting them out there. The Institute of Medicine, I thought, did a great job. I think what happened, to tell you the truth, is when I became, what happened was there was an election. And I had been Surgeon General under President Clinton, and we had set these goals, these disparities goals. And I think when the new administration came in, they allowed me to stay on for a year, even asked me to. They had some doubts about the validity of this whole thing about disparities. So the great thing that happened, of course, was they funded the Institute of Medicine to do a study. And it was that Institute of Medicine's report that came out in 2003 that really define disparities, and this is one of the great lessons here, showing the difference in quality of care in different groups in this country, minority versus non-minority. Major difference when you study the quality of care that people received when they got into the system. And there were many different reasons for this, but I think that disparity was very telling. So a word about culture. We've taken a special interest in this at the Morehouse School of Medicine, and we now have a program in culture competency. But it was this report that we released in the year 2000, I believe, Mental Health, Culture, Race, and Ethnicity. And it was about mental health, but one of the things we showed was how critical culture is, that culture actually does count in how people manifest and describe their illness, how they cope when they get sick, the type of stresses they will experience, and whether they're willing to seek treatment. Culture impacts all of those things, and as we work with people in community, we have to be aware of that. So people bring their culture with them. And we in medicine, of course, and public health have our own culture. And because of that, sometimes we fail in our attempt to communicate effectively with people in the community. We don't understand their culture, they don't understand ours. We operate from the perspective of our culture. We even used to say there was a culture of medicine, and that was not always good. But the way people are diagnosed is influenced by culture. The kind of treatment that they offer, that's what the Institute of Medicine showed. And how services are organized and financed are all influenced by culture. And so there is this issue of how do we bring these cultures to the point where people benefit equally. Now, the crash course in culture competency at Morehouse deals with how do we help medical students and how do we help physicians in practice to relate to people of different cultures. And we call it crash because we want them to consider culture, want them to respect the culture of patients, to assess and affirm, not necessarily agree. Now, if somebody comes to me and said that they have to have their food highly salted in order to eat, and that's their culture, well, I tell them they need to change their culture because that's not good for your heart. So I'm not saying that we have to agree with everything, but we have to understand and appreciate where people are coming from if we're going to be effective. We have to be sensitive to culture, and we have to be aware of our own culture. And then finally, we have to have enough humility to realize that none of us will ever be experts in other people's culture. After we released this report, I remember being invited to Seattle to this Asian Counseling and Referral Center. I never will forget it because they were serving a population of Southeast Asians, and the population spoke about 30 different languages or dialects. And they had done a very smart thing. They had found people in that community, brought them in, provided necessary training, and they became members of their team. They were culturally competent because they had integrated the community into the health system. This community was no longer out there. The community was, in fact, a part of the Asian Counseling and Referral Center. And that's why they became successful, because actually Asians have more stigma surrounding mental health than African Americans do, and we have tremendous stigma and have trouble getting people seeking help for mental health, but Asians have even more. So they were very successful in overcoming that stigma, and it was something to behold. Well, now this is the School of Public Health, so you're very familiar with the public health approach, and so I want to make a point about the public health approach, where we say that we always begin by trying to define the health problem, and we do that with surveillance and research in the laboratory, and sometimes it's finding the organism, sometimes it's defining a pattern. And then finally, then after that, we want to define the cause, the risk factors that are involved with this problem. And the third step is, can we find a vaccine? Can we find an antibiotic? Can we find a community program that ameliorates this problem? Can we find a program that begins to reverse the epidemic of obesity in this country? Can we find that? And then finally, if we find one that works in one community, can we replicate that in other communities so that gradually we begin to turn this thing around? I happen to think that we're making some progress. The last reports out of CDC suggest that we have plateaued, but it's dangerous, of course, to get comfortable with plateaus. So I think we have to keep working hard on this issue if we use that as an example. And of course, I'm using that because clearly obesity is one of those major risk factors that disproportionately affects African Americans and Hispanics, and to a certain extent American Indians. It affects all of our groups and all of our children, but it disproportionately impacts those groups that already have the highest rate of cardiovascular disease and death and diabetes. So what we need in health reform is a balanced community health approach that balances health promotion, disease prevention, early detection, and that moves toward universal health care. I hope Congress is listening, because if we get nothing else, we really need we need to have a universal system of health care. And we need to really invest our money better in the future than we've had in the past. We're spending $2.5 trillion a year almost on health care, and yet we're leaving out almost 50 million people. Something wrong with that picture. So we need balance. The Surgeon General's prescription is something that we developed in 1999 and presented it at an international conference on health promotion and disease prevention. And I was telling the story, last week I had to speak to the Atlanta Leadership Forum, and I was really rushing. I was a little late because I had just gotten off a plane. So I knew it was their last lecture, and I was trying to figure out whether they were going to tolerate me. So when I started, I said, well, suppose I told you that I have this pill, and this pill can reduce your mortality risk by 50%. It can reduce the onset of diabetes, risk of onset of diabetes by almost 60%. It can reduce stress in your life so that you have better psychological well-being. It can enhance your sexual potency and enjoyment. They all woke up then. It can do all of these things. And then by the time I had them all awake and excited, I said, you know, I don't have such a pill. Don't have that pill. But if you do what's on the Surgeon General's prescription, surely enough, moderate physical activity, at least 5 days a week, etc., you will in fact reduce your mortality risk. You will reduce the risk of onset of diabetes dramatically, reduce the risk of cancer. You will reduce the risk of sexually transmitted diseases and unintended pregnancies. And you will enhance your sexual potency and enjoyment and deal better with stress in your life. That's what the Surgeon General's prescription is all about. Not a single drug on that prescription. It still took me 4 months to get it through the FDA. But there's not a single drug on that prescription. But let me just say what I think the point is here, and you may have heard this story before, but it's a story about a man who was traveling across the country in a hot air balloon, and at a certain point he realized that he was lost. He had no idea where he was, so he decided to lower the balloon to see if he recognized anything. So he lowered the balloon, and he didn't see anything he could recognize, so he just kept lowering it. And it was actually only after he got to about 30 feet above ground that he spotted this man working in the field below. So he yells out, "Where am I?" And the man stopped digging, and he looked up and said, "Well, you're in a hot air balloon about 30 feet above ground." Or the man in the balloon said, "Well, you must be a scientist. Do you work in science?" And the man said, on the ground, said, "My goodness, I am, but how in the world did you know that?" And the man in the balloon said, "I knew that because what you've told me is technically correct, but it is of absolutely no use to me right now." Well, not to be outdone, the man on the ground said, "Well, you sound like one of those policymakers from Washington or somewhere." And the man in the balloon said, it wasn't Senator Sarbanes, "I'm a leading policymaker, but how did you know that?" And the man on the ground said, "I knew that because you're in the same position you were when we met. You don't know where you are, you don't know where you're going, and now you're blaming me." Well, there's a moral to that story. And it is that, you know, we need to continue to do the research, the science, but we need to find ways to bridge the gap between what we know and what we do. That's a real challenge that we face in this country. That's a real challenge that we face in eliminating disparities in health. I'm going to close with this Commission on Social Determinants of Health. We had a tremendous time. There were about 24 of us. We traveled all over the world looking at what different countries were doing And without dwelling on it, the J.W. Lee, who started the commission, and he died before it was finished, said that this commission is trying to foster a global movement that places health and fairer distribution of health and better overall population health at the heads and hearts of governance. He recognized the role of policy. And one thing that was very clear is that even within and between countries, we see the effects of social determinants. In other words, if you look at different socioeconomic levels within the same country, then what you see are different health outcomes. Yes, Kenya is different from Brazil and Indonesia in terms of mortality rate, but within Kenya, there are differences on the basis of socioeconomic status. That's the picture, and when you really examine it, whether you're looking at Kenya or Sweden or Norway, what you see is this relationship. So the Commission talked about health inequities within and between countries as socially unjust because they were related to social determinants. They were related to poverty. They were related to education. Social, economic, political, cultural, all of these factors are key drivers of health inequities. Tackling health inequities will require action on social determinants of health. I want to close with that point, is that until we are willing to tackle the social determinants that includes employment, safety, all those things, we will not eliminate disparities in health. Health equity is the responsibility of a diverse group of social actors. It's a major message for us in public health. I think McKinley, this population model is interesting in that respect because McKinley said that even if you're dealing with a problem like obesity, you got to attack it downstream, midstream, and upstream. Downstream, you got to deal with the individual, and that includes health care. Midstream, you got to look at our communities. I mean, do we have grocery stores, supermarkets? Is it safe? Do the schools require physical education? And then upstream, we're looking at policies. Are we as a nation supporting the kind of policies that are going to improve the health of all of our people, going to remove barriers to access to care, remove barriers to healthy lifestyle? But as we discussed with the students earlier, what we need from you and from future leaders, we need people who care enough. But we also need people who know enough. It's one thing to care, but we need people who know enough to implement the best strategies. People who are willing to do enough, that requires a lot of courage. And then we need people who are going to be persistent. John Gardner was right. You remember John Gardner. Life is filled with golden opportunities, carefully disguised as irresolvable problems. Thank you.
I would ask the panel to please join us in the front. And I could not think of three better individuals to reflect on the presentation. Let me just ask anyone who's standing, there is plenty of room, so I would really, unless you're really comfortable standing, would just crawl over people and grab a seat, please. I'd like to start with your far right and start with introducing Diane Bell McCoy. Ms. McCoy is the president and CEO of Associated Black Charities. She has extensive Baltimore-based experience. She is a graduate of the University of Maryland, worked in social work, worked in substance abuse areas, subsequently worked in D.C. in child welfare, and undertook with the team a major child welfare reform initiative there, and worked on anti-poverty initiatives. The focus, before coming to the Associated Black Charities, Ms. McCoy was a senior fellow at the Annie Casey Foundation. And really the soul of what Associated Black Charities is to bridge the health and economic wealth gaps in Maryland. So it so closely ties in, I think, with what Dr. Satcher was talking about. To her right is Dr. Pastor Francis Tony Draper, better known as Pastor Tony to many of us. Dr. Draper, it is extraordinary that she has found time to work, because she graduated from Morgan State, subsequently got a master's degree at Johns Hopkins in education, subsequently got a master's degree at the University of Baltimore in business, subsequently got a master's degree at Loyola University, and subsequently got her doctorate at United Theological Seminary. She served as the president of the Afro, which is, as most people here know, a landmark newspaper that was founded by her great-grandfather, and subsequently, with the calling, went into the ministry. And I would also say she is not only very active at Morgan on the Board of Regents, but is very active here at Johns Hopkins. Speaking about active here at Johns Hopkins, to her right is Dean Michael Clagg, who needs in this audience no introduction, but gets one anyway. Mike came to the position of dean here from the Hopkins School of Medicine in 2005. He has served as the director of the Welch Institute, as the director of the Department of Medicine, as physician-in-chief of the hospital, as the department head of the division head of general internal medicine, and for this conversation, even more importantly, has a 20-year-plus history of doing community-based research. Issues such as hypertension and renal disease are central areas of his interest and work. So thank you all for joining us. And maybe I'd ask you, Diane, to lead off with your comments and reflections.
Well, first of all, thank you very much for the opportunity today. And first of all, thank you, Dr. Satcher, for your comments. And absolutely, as I said to you earlier when I was introduced to you, that I was looking forward to responding. My response is probably absolutely 100,000% in agreement. First of all, I will start off there. But I want to start back in terms of what we were also asked in terms of our response. I also talk about some examples in relationship to this issue of health disparities as it relates to Baltimore. And I would start off by first reframing slightly in terms of description of me, in terms of it gives you my social work background. I would tell you that I am actually an economic development social worker. There's no such title. I made it up. But that is who I am in terms of what I believe in terms of this issue as well as others, and the interconnectedness between health disparities and wealth disparities and what that means in Baltimore particularly, but what it means in the state and in this country. I would also start off with kind of a different kind of paradigm shift that has been borne out in the work and the research that we've done, we in the Associated Black Charities have done over the past 3 to 4 years around our agenda of closing the health and wealth gap. And that paradigm shift that I would share with you is a paradigm shift to understand that low income, working poor, fragile middle class, African Americans and Latinos need to be viewed as part of the solution and not the problem. And they also need to be viewed as assets for the region's growth and assets in terms of the economic development of this city and of this region. That's a different way of looking at the issue in terms of poverty and poor people and the health disparities. They really are a part of the assets of our closing the gaps for everybody in this room, regardless of your race, in terms of the taxes you pay, the taxes you don't pay, the quality of life around you if you live in the city, is dependent upon not seeing an African American population that the city is a majority of, and whether they're low income or fragile middle class, as part of the assets. Changing that vision, shifting that paradigm, I think also shifts how we interact and what we do on the ground in terms of understanding they're part of the assets, the economic assets for this region. So my example to you of things that are addressing health disparities in Baltimore are really examples as it relates to that paradigm shift. And so I would tell you that even here at Johns Hopkins, one of the actual examples of making a difference in health disparities is actually happening down the street from you in terms of the biotech park. To the extent that that park is successful, not necessarily being just a biotech park, but bringing jobs and offering a career path, an opportunity for low-income African Americans that live in the surrounding area or live in the city, then that becomes part of the response. Many of you have seen the data that's come out of the health department, actually in partnership with the School of Public Health, as I recall, in terms of the demographic outcomes in the city, in terms of, we talk about the tale of two cities, Park Heights versus Roland Park. I think if I'm correct in my memory, it's 20 years difference in the life expectancy. Is it 20? 20 years difference in the life expectancy. And the difference between those two significantly is income and race. Now, if that's true, the issue is in how do you close those gaps and pay attention to that. It's not changing that you don't want to pay attention to some of the health indicators and focusing on the health issues, but if you don't focus on the social deterrents, and I'm very clear it's an economic conversation, then all we will do is continue to slide backwards in terms of making any real gains in terms of change in the community. So I'd offer you that as an example, but also offer you here, even at Hopkins Medical School, another example. The other piece of work that I did many years ago was led over 10 years the city's empowerment zone, which is $100 million from the federal government, and thank you, Senator, in terms of moving that agenda forward. But out of that agenda, I can tell you what we learned in working with Hopkins, and Hopkins has since taken that and run with it in a very positive way, is that the hospital had a number of workers that were in entry-level positions, that had been entry-level positions for anywhere from 10 to 15 years. And they hadn't moved out of that entry-level position despite all the effort that the hospital was doing to say these are the opportunities available for you. Many of them lived in the surrounding community, low income, didn't even believe that those opportunities were in fact available for them. Their belief about who they were in terms of those opportunities, despite all the tools that Hopkins felt it was making available to lay out that information around those job opportunities, people still did not cross the line. For me, that's another conversation around overall in this city in terms of pedagogy of the press, but that's not the day for this discussion. But the issue around that was when Hopkins moved forward, it really was the leadership of Pamela Polk, moved forward to actually we incubated developing career coaches, where people then got the opportunity to actually see themselves differently and see themselves as assets, and that they could, in fact, do something different and could move up that career ladder. That's not the answer for everything, but I would tell you concretely, in terms of from an economic development perspective, that we also have tested tools that changes those health outcomes by changing the economic outcomes. And I will tell you things like customized training for low-wage and low-income earners makes a difference in terms of over 4 quarters, moving their income from $4,000 to $9,000 to $12,000. That's concrete, that's measurable. But then how do you move that to public policy? How do you begin to change the policy that we implement here in our state in terms of recognizing what that economic development does? My last concrete example, being mindful of the time, would also be understanding that what makes a difference in a city that is 65% African American, largely poor. What will make a difference in terms of, I talk about both getting people the opportunity to grow those skills, opportunity to pay attention to the ex-offender and giving him a viable opportunity, but also what will make a difference in terms of having a more viable group of African American businesses, because African American businesses hire low-wage workers at a greater rate than non-African American businesses. Joint Center research. I don't do anything unless it's verified by research, and I don't do anything unless we focus on outcomes. And so out of that research, if that's true, if I understand that's true, Doctor, and I understand that is a part of making a difference, then I have to ask the question, in a city that's 65% African American, there are exactly 7% of the businesses in this city are African American businesses with employees. 7%. If I understand the difference between education in terms of outcomes, I also would have to ask myself the difference even when we get past K through 12 and acknowledge their improvements in the K through 12 system, and we need to continue to push for that. Then I would go to higher education and ask, why in fact do we have one of the lowest graduating rates for African American students? We celebrate their going in the front door and they drop out and don't complete. And that means that they come back to communities if they come from here, and there are opportunities. We know a college degree leads to $1 million more over their lifespan. So my focus in terms of understanding the examples that are working, we have too few of them. And that is a concentrated focus on how do we combine our public health conversation with our economic development conversation in terms of focusing as part of the way to address some of those social deterrents as moving forward, and not just from a poverty perspective. Understanding this town, as we're talking about African Americans and the issues of health disparities, we're also talking about a fragile middle class. We're talking about a working poor. So that is clearly part of the challenge in moving the agenda forward, and that's a part of what we focus on, and then how to move that to a public policy conversation. So those would be my examples, and how to, in terms of respond to you, I think concretely on the ground, we've got to do more of that if we want to address these issues, as adding it as a part of what already is going on as well.
Let me too thank you, Dr. Satcher, for your thorough presentation this afternoon. And let me say to you, Bob Blum, you know it's dangerous to give a preacher a mic in the middle of the week. And let me thank Diane for her remarks and for the $4 million raise. All of the, you said education is about $1 million over a lifetime. Yes. So I've been to school a lot, so I'm looking for the other, for the four. I'm sure you're going to sooner or later. Let me say a couple of things. About 10 years ago, I had the opportunity to serve as a consultant to the city of Chicago. You all may remember when the legislation changed from AFDC to TANF. And their hypothesis was that if you retrained their workers who had to deal with the recipients of the TANF, temporary aid to needy families, if you trained them differently, then the outcomes would be different for the people they had to work with, because under the AFDC system, people were treated not as clients or as those who were to be respected, but they were just a number. They were people who some viewed as people who deserved, if you will, to be treated poorly because they were poor. And so my task was to go and to spend week upon week upon week training people to rethink how they interact with other people. What was an eye-opener for me was that so many of those who worked with people who were receiving these benefits had been trained so poorly from the beginning that it was very difficult for them to change how they felt about the same people just because the name changed. But they found over time, when they looked to see what the outcomes were later, that when people are treated with respect, and Dr. Satcher talked about this, then you get a different response. Fast forwarding it some to many years later, because that was 10 years ago. In Dane County, Wisconsin, they recently announced a dramatic drop in their infant mortality statistics in their community. They're not sure what has accounted for that, but they are thinking there's an interesting surmise about a change in the way that prenatal and other care is delivered to poor black women in Dane County. And so they have a large one-stop health center focused on their needs and located in their community, where they perceive that those women are treated with greater respect by the providers of care than in most typical medical institutions, Consequently, they found that people are more likely to seek and to continue care. So what am I saying? I'm saying repeating some of what Dr. Satcher has just said. The social determinants are so important. So often we focus on the science, which is important, and I'm not a scientist. I may go back and study that one day. I'm not a politician, Senator Sarbanes, although I have lots of respect for the politicians, and I see 2 or 3 or more in the room. I am a community person and who deals a lot with social determinants and what people are going through in their lives. And so often people don't feel respected, and they ultimately have to take as much responsibility for their health and well-being. I also would want to say, so I think that's important. That's very, very important. Dr. Satcher, you also raised a point about research. I serve as the community member on one of Hopkins' institutional review boards. And I see our regulatory specialist in the audience, and she's shaking her head in agreement. We recently had a very lively discussion about a research protocol that was dealing with prostate cancer. And I was concerned because the recruitment section, there's a question that asks about minorities and women and inclusion. And the answer was that it was going to be representative of the community, which is the Hopkins community, and it gave the numbers. But the recruitment for African Americans for this particular protocol, given this disease and given the prevalence and given all the disparities, was only going to be about, I don't know, it was going to be one or two people out of the 20 that they were trying to recruit. And so I raised the question about how did that really mirror the community? And so we have to do a better job in our research protocols. We have to do a better job of recruiting. And I understand, I haven't been on the IRB but 4 years, but I understand the difficulty and the challenges sometimes of community-based research. But if we're going to do research where we're going to generalize for the population at large, especially in those areas where disproportionately the disease affects people of one ethnicity or the other, we must make sure that the research is as inclusive. If not, the results will not mean a thing. And so that's the second thing that I really have a passion about is the research. The other thing, we were asked to talk about solutions. And I want to lift up something that's happening right here in East Baltimore that you may or may not be aware of. In the Eastern District, there is a police major, and I'll call his name. His name is Melvin Russell, who has been the major of the Eastern District police force here for maybe a year and a half, who came to the community and he said very clearly, policing will not get us out of what we're facing. One of our major health issues here in the Eastern District and throughout Baltimore City is violence, and the Eastern District is the most violent district in the entire city out of the 9 police districts. He said, I can put more men on the street, more women on the street, I can have more weapons, more jails. None of that is going to do anything to solve the problem unless we as a community work together on an equal playing field. Not with the police pulling their weapons, not with a judge just sentencing people, but we have to work together. And so what he's done, and this may be a model for the other 8 districts and indeed for the state, he has gone into every segment of this district. He's talked to educators. He's talked to health policy makers. He's talked to the senior on the corner. He's talked with business owners, but not just to talk with us. He's talked with the faith community, and he's brought us to the table. And he said, this is your community. And I'm not going to solve this by myself. I cannot police my way out of that. If I can repeat that again, we need to work together to get this done. And it's more than just a series of meetings. And he calls the team that he's assembled, and if you're on that team and you know Major Russell, that means you get about 10 emails a day from him. But he calls that the Eastern District Transformation Team. So much so that in the faith community, he's asked us He says, when there's a fire, when there's a shooting, when there's a concern in the community, I need a first response team that's not the police. I need pastors and other faith leaders to sit with the child who may have just lost a father to violence, to sit with the family whose home has now been destroyed by fire. He said, I need to know I can call you at 2 o'clock in the morning and you're going to answer the call, but not just answer it. You're going to get up out of your bed and you're going to go and see about that family. He said to the business leaders and to others, when there's a tragedy in our community, we need to do more than say, we're sorry that happened to you. And so he secured 2 warehouses that now are stocked with food and clothes and appliances and other things, that when something happens in this district, then the people can go there and they can get what they need. And so a solution, and we know this, is for us to figure out how we continue to work together. As Diane has said, looking at our community and the people as assets. We're in this together, so it's not an us and it's not a them, but it's something that we must do together, and there must be a sense of urgency about it, that we get it done sooner rather than later, and that we work together with the Johns Hopkins of the world. I said to Bob Lum today, I'd like to see a conversation, he says we're working on it, where it's not just Hopkins, but it's Hopkins, it's the University of Maryland, it's the other hospital systems that are in this state putting the best minds together at one table. It's not just East Baltimore and West Baltimore. You know, this is a very divided city, still East and West, but we're pulling together because this problem of health disparity and health inequities affects all of us, and it really affects us equally, because you can walk your 30 minutes a day and eat your 5 vegetables a day and abstain and have safe sex and all and take the Surgeon General's prescription. But if I take the prescription and my neighbor around the corner hasn't even seen the prescription, and my neighbor in the county that's just driving through on 695, sooner or later, all of us will be victims of health disparity and health inequity, because our entire community must be healthy if any of us are going to advance to where we believe we should be. And we should be further along now in 2010. And it shouldn't take us 40 years to get a health reform bill passed this time so that people can get, yes, access to health, but so that all of us would have a healthy and viable community. Thank you.
Sure. Well, tough act to follow. 2 tough acts and 3 tough acts. And I think everybody in this room believes in the multiple determinants of health. We believe that in how we live and believe in what we do professionally. And so in many ways, your talk, and I'm not sure, you have so many titles. I'm not sure whether to call you Secretary Satcher, whether to call you, Director, to whether to call you Doctor. But David, okay. So, in a sense, you were preaching to the converted when you spoke. But boy, you're a great preacher. It was a great talk. So we were asked to talk about examples, and I think one of the things I liked very much about your talk was the metaphor of leadership as a relay race. Because when you try to affect change, you often fail. And we talked earlier today at a meeting about family planning and what's happened in this country to the family planning initiative and women's right to control what happens to their bodies. And I think the metaphor of a relay race, where sometimes you drop the baton, but then you pick it up and go on, is a good one, and can provide some solace to us sometimes when we worry about health care reform and what's happening now in Washington. The example I want to use is, Bob said, my background is in medicine and epidemiology, and I practiced medicine in this area for 20-plus years at Hopkins Hospital. And I see Pamela Falk back there. Pamela, would you raise your hand? The person you used as an example for how for an intervention to improve access to employment and advancement in employment. And one of the difficult things we would do is you would take care of people with high blood pressure, and here you would see malignant hypertension, which is a disease that doesn't exist in America by and large. I mean, it just doesn't exist except in a place like East Baltimore, where people don't have access to health care. They don't have the minimum access to medications that prevents malignant hypertension. Malignant hypertension is that severe form of hypertension that FDR died from, where you get pulmonary edema, you get strokes, and your life expectancy is very low. So we would see these men come in, and for a whole variety of reasons, some societal, some their personal setting, would not be able to get medications and would be dying of something that hasn't existed in the U.S. since 1960. And so the solution I want to talk about, I want to borrow from our colleagues at the School of Nursing, where Martha Hill was the dean. And she started a study called the Young Black Male Study. And I was only peripherally involved in this study because sometimes I would get referrals from them. But what they did is they built on the public health model. So we all know about J.B. Grant. J.B. Grant was an alum of our school in the 20s who went and worked for the Rockefeller Foundation. And one of the things he did was to create the Barefoot Doctor program in China, the idea of community health workers. And so Martha built on that model of a community health worker and devised an intervention where you had an integrated team of somebody who lived in the community, who was educated in how to improve compliance, side effects of medications, be a liaison with the health system, a nurse who provided the care, and a doctor as backup. And in addition, that group, the sort of intensive group, got education, got facilitatory interventions to help them get the care, to have if there were issues related to the home, to sort of help create a situation in which they could be compliant. And then there was a usual intervention group where people were followed. There was about 300 men in this study, and they were randomized to the community health worker, nurse practitioner, physician group, or the usual care. And over 5 years, what they showed is that you could lower blood pressure. Well, in both groups, blood pressure improved a lot. Hypertension control increased in both groups, just with the intervention of having people have their blood pressure measured in the usual care arm and having an interaction with a nurse practitioner once a year or so. But so it improved markedly in both arms, improved more at 3 years in the intervention group, and then showed that the end organ effects of high blood pressure were ameliorated in the intensive group. So one of the things we look for is how big is the heart, how thick is the heart, an EKG, and that improved. So it was a success. Now, but there were some sobering things in that study, and one is that they reported on the mortality at the end of 5 years. And 30% of the deaths in the group were due to narcotic addiction, alcohol abuse. Okay. So that's a study that is emblematic. It's representative of our, we talk at the IRB about do we have a representative study. It was a representative study. And it just shows that although you may be working on this one thing, there's a huge plethora of problems that you have to address. Mm-hmm. The other thing I would say, to go back to the metaphor that you use as a relay race, is when you see studies like this, I think the issue in improving the health of our populations is not lack of knowledge. We know what to do, right? We know what works. It's getting it done, right? And that can be an incredible frustration. It's not a knowledge gap. It's a want to do gap, or a being able to do gap. And as we move forward, that's right now. I believe in research. My whole career has been research, but it does resonate with me when you talk to Tom Frieden, for example, who's head of the CDC, who says, we don't need to do more research, we need to do things. I think both are true. We need research, but we need to do things. So finding that political will is the challenge. And so for us in this room and everybody at this table, we believe that health is a right. I think we believe that health is a human right. We believe that access to health care is a right. It's not a privilege. And the war, if you will, or the argument that we need to win in this country is it a right or is it a privilege? And if you think it's a privilege, then you have to earn it, you have to have the money, you have to be born, you have to pick your parents well, right? And we can't do that. So the challenge is, I think, the big macro issue, how do we get America to where Norway is, or Sweden, or where every other developed country is, right? Healthcare is a right. And then everything else will fall into place. So that's it.
You will notice that there are microphones on either side of the room, and so I would welcome you to join the conversation by either making comments or raising questions.
Yeah,
Please introduce yourself.
my name's Rebecca Cantor. I'm a doctoral student here in the Department of International Health and Human Nutrition. And I just want to say, first of all, that in general, just going to school here in East Baltimore has been just as much of an education, sadly, or perhaps even more so than being inside this building. And so my question is mainly aimed at Diane, but also maybe for Dean Clegg as well. I was I welcome the fact that you brought up the biotech park, because I heard a lot about the biotech park being around here, and one of the things that I kept reading in the papers was how many people were being displaced from living in this area. So I was almost shocked when you brought up the biotech park, but didn't talk about negative aspects of it, but more of a positive aspect. But then you went on to talk about how much we need more African American businesses and more African American employees. And so I was wondering if you could comment maybe a little bit further on the biotech park, because to me, if you're displacing these people out of East Baltimore where they lived and sending them to the county, some of them, maybe not all, I'm not familiar, are they going to come back and work in the biotech park? The biotech park isn't, my impression, be African American biotech. So yeah, if you could just elaborate a little bit further on your experience with the biotech park and the quote-unquote collaboration between the community and Hopkins with the biotech park.
Okay, thank you. There are two parts to the biotech park for me in terms of that. One, I'm not sure that there are a lot of people that believe this or understand it, but it is part of my experience, and it's been true nationally. I'm not sure people understood in terms of developing a business park in East Baltimore that you also absolutely had to displace people. You can't do physical development and human capital development at the same time, same place, in a deeply disinvested community. It's not possible. So one, I think that was just, I'm not sure what it was, but it certainly couldn't be done if you were going to build that. And so you displaced a whole historical community in so many ways. You will have a number of the participants in the biotech park, and let me disclose something so my hands on top of the table. I'm on the board of the biotech park, but I'm probably the most vocal, one of the most vocal along the community about what that damages and making sure the community's voice and making sure they're whole. But I would say that out of the Casey Foundation commitment, and I think some element in terms of Hopkins, there was a goal to make sure people that got dislocated in place had additional resources. That doesn't change how being uprooted from your community. It doesn't change how horrible that feels. It doesn't change losing relationships. It doesn't change any of that. But they did it, okay? It's done to that extent. And the issue of where they moved to, most of them stayed in the city, and most of them stayed largely on the northeast part in terms of Baltimore. There's some that's still in East Baltimore that don't have better off lives from my perspective of looking at data. And I think we have an obligation to pay attention to that. That's one part of it. The other part of it, it's now there. In terms of that, one of the original studies for the biotech park talked about not the jobs at the park. That's not the economic generator in my mind. It is the jobs and the commitment to the jobs that lead to the park, not the construction jobs, although there was a commitment to that and people from the community were high. It's the jobs that benefit when you talk about the things that actually go into a biotech park, the services, the products. And I'm not talking about low-level jobs. I'm talking about, as you talk about even some of the jobs that are in healthcare right now as a pathway in terms of opportunity. So I don't think it's a panacea by any stretch of the imagination, and it's not this wonderful, great thing, but it's there. as we go to talk about developing more businesses in terms of the African American business community, along with the former mayor, made a commitment that went signed in writing about economic inclusion to ensure that the African American business community benefited in terms of that. And so they tracked that number. It's still not enough in terms of that, but there were some tools. I think we've learned some things from it that certainly won't be repeated in terms of future. But to the extent that that park grows and more business, and I want to add that I don't know that Tony's had the opportunity, I'm sure she has, but I want to add something very publicly right now. The current president of Hopkins, in terms of Ron Daniels, your new president, I think is one of the best things that's ever happened to Johns Hopkins, in my mind, to the city of Baltimore. Because other than feeling like Hopkins was going to be this island unto itself, he's embraced how do we make sure that this community benefits, and how do we encompass all that and make sure, and even his neighbors in terms of other Sojourner, how do we really do this together in terms of real jobs and economic benefit? Until that happens, and this is not just this island over here, nothing. So that's the opportunity I'm referencing. But the history is the history.
Hi, my name is Jen Lopez, and I'm a student at the School of Nursing here at Hopkins. I'm also part of healthcarenow.org and the Center for Underinsured and Uninsured. I have a question about the current healthcare bill. Is this on?
Yeah, louder.
The current healthcare bill, to me, is nothing more than abject capitulation to the insurance and pharmaceutical companies, and it still doesn't get to the core of the problem, which is the cost of treatment and medicine. As I'm sure you're all aware, there was a study that came out last year by Harvard that found that healthcare disparities amongst different ethnic groups and people of different socioeconomic status, it drastically declined at the age of 65 when Medicare kicked in. So to me, this is strong evidence in the support of Medicare for All and the single-payer system. And I'm wondering what your thoughts are about that, and if you advocate for single-payer.
Well, let me just say this, the present health care bill as it is leaves a lot to be desired. I guess you could argue that there is no present health care bill, but based on what we're dealing with, what was passed in the Senate, it does leave a lot to be desired. So what does it do? And let me just mention three things. It does no longer allows the insurance companies to drop you for a pre-existing condition. I think that's big. Or because you changed jobs, or because it immediately adds 30 million people at least. People who are uninsured will be covered by insurance. So it moves in the right direction. I mean, sort of like Massachusetts, I forget how many people were covered. This bill, I think, would be 94% of the American people would be covered. Massachusetts was about 95, they're up to 98 now. So I would be really disappointed if we don't get any bill out of this Congress. And I certainly understand about single payer. I've worked in countries with single payer. I know the value of them. Do I believe the American people, with our heritage and the role of business, is going to accept right now a single payer bill? I don't think so. I don't think Congress is going to pass one. And that's unfortunate, perhaps, but I think that's the fact. And so what do? Do you say it's not perfect, so I don't want anything? Or do you say I'd love to get 30 million more people covered who are not covered? I'd love for people no longer to have to worry about going broke because they got ill, as they do now, in many cases, or because they lost their jobs or changed jobs. I think we cannot afford to come out of this game without that progress. So I hope we don't.
Maybe Senator Sarbanes.
Hi, I'm back.
So she's back from an earlier talk today.
My name is Dr. Cheryl Mason. I am an MPH student, candidate 2010, Johns Hopkins. And I have learned a lot at this school, especially as far as things that I learned in environmental health. And one of the things I learned is that we are losing insects and the Franklin bumblebee and lions and tigers and bears. And we have lots of programs and attention on that, but one of the species that we're losing and I don't see enough attention paid to or solutions is what's happening to the African American family, but in particular the African American male. And I'd like to know what public health solutions, not ideas, not research, because we have plenty of research under Dr. Levis. What solutions are we willing to put in place to save the species? Thank you.
I think we have a lot to do in order to do that. I think, obviously school dropout is one of the things I've been most concerned with, and supporting programs to try to keep children in school, including mentoring programs, which we have one of the best, I think, in Atlanta. Many of us, quote, successful black men have made a commitment to mentor black students from disadvantaged households and communities who have great assets but who need help. So we've been doing that, and now we're looking at the prison reentry program. So many young black males are ending up in prison until we almost have to work with that institution as closely as we do any other to make sure that number one, we try to keep kids from going there, but once they get out, how do we help them to get back into the community and to be productive? Those are some of the things that we're doing. And part of that prescription thing was trying to say to these men, many of whom have done well, and they still die much younger than they should. So when I went back to Atlanta, the goal was to develop a model where we get these men who are fairly successful to begin to take care of themselves so that they don't keep dying young. And then they can really do more in terms of the community and the children and other black males.
I do want to add to that. The other part of what the question was asked was also talked about the species that are dying in terms of insects and what we're trying to do to save them and to stop that extinction. For me, I would repeat that part of that shift that can happen concretely in public health or any other sector as it relates to the African American male alone is to understand the same way we treat that is the African American male is an asset, not a liability. We pay attention to the disappearance of those species because we're concerned about the absence to our environment, to this country, what it means to another country when tiger lion disappears. We want to be equally concerned as understanding the African American male as an asset and not a liability. And I think you change the paradigm, you change the lens of how we look at African American males, then you change what we will do about it.
Bob, can I would just add one more thing, Cheryl, and that is, I thought that Dr. Satcher in his talk, he said many important things, but one was the importance of hope. And desperate people do desperate things. People can go through so many trials and travails if they feel there's an opportunity to come through the tunnel, see the light at the end of the tunnel, and to succeed. And when we remove that opportunity, and many of our national policies over the last 10 years have done that, they've diminished people's social mobility, then people get desperate. And so I would just echo what you said in your talk about the importance of opportunity and hope for everybody, but especially for black men.
I want to add that stereotypes play such an important role. And intervention can't be when they're teenagers and young adult men. And as much as I know that we need drug rehab and prison reentry programs, but I want to just expand on something that Diane said. We can find money for anything else we want to find money for. We're going to have to spend the money to change, if you will, the mindset of Americans around race and around how we view people of color and come face to face with the policies that we have that exclude people. So often when people talk about young black boys, they're thinking in their mind that when they grow up, they're going to fit the stereotype that we see on television. So there's some things, there are many things I believe that we should just spend more time and resources on, including the images in the media, including some of the music that we allow to be in our society. It didn't happen overnight, and it's not going to get solved overnight, but it just starts at such a young age. If you go into an elementary school and even watch and just sit and observe sometimes how the black boys are treated in the classroom, you'll notice early on the young black boys are stereotyped and labeled even before they have a chance to get to middle school. And I know there are lots of programs now around gang violence prevention and intervention. And that's important. But we have groups of people that are looking for some place to belong and some place to be accepted because the society that they're raised in crosses the street when they're on one side and you cross to the other side. And that's whether you're black or white, who will drive 695 20 minutes out of your way to keep from coming through the city. It's because we've bought into the stereotypes about black men and black males, and I think we have to spend some concerted effort to undo what we've allowed to happen in our communities.
Thank you. Two final quick questions and quick responses. We'll only have time for two more, I'm sorry. So, David, you have the last, but you have the second to last.
Hi, my name is Stephen Ragsdale. I'm an innovations coach at the Center for Innovations in Quality Patient Care, and I'm also a student at the School of Public Health. I appreciate all of your comments today, especially as they relate to the economic problems surrounding this. Quite frankly, we don't talk about that enough, when we're talking about solutions. There's always two sides of the balance sheets. Can you guys talk about, like, the cost of doing business this way? When you talk about assets, our inputs, what is our current condition? What is the cost of us continuing down this path?
From a local level, and unfortunately, I may not remember this number correctly, Steve, but because I'm co-chairing one of the incoming mayor's transition teams, I can translate it to you in terms of it's something like a $512 million deficit we're facing in taxes in this city in terms of revenue. That's part of it. That's the cost. Because if a city that's so reliant upon property taxes to general fund to pay for services, and everybody wants the property taxes to come down, and so do I. But the reality is that's your source of funding, and your services, when you've got a population that's largely poor, largely black, largely uneducated, all those issues, then what you have higher costs for services. And the moment you try to bring that down, the services, because you want to change the property rate, you're going to bring that down in terms of this side. So that is exactly the cost difference we're facing right now as a result of not investing strongly and opportunity and access for opportunity regardless of race, and understanding the city is largely African American, and how do you change the economic outcome both in terms of from a business development to workforce, not just work, but business. And I'm going to make one plug because Sylvia Brown is sitting in this audience. If Hopkins were to invest just one little bit of their dollars in terms of investment dollars into Brown Capital, what a difference that would make in terms of jobs that Eddie Brown could actually create. Thank you.
Let me admit that my first question has been stolen, but I have another, and it's for everyone. I always have one, right, Dr. Satcher? Mental health. Mental health is a huge problem for the African American community. What can we, at the community level and the public health level, what actions do we need to take to deal with mental health from where we are?
Yeah, I think the mental health problem is much greater than what we have thought because of the impact that it has on all of the other problems. I think there's an epidemic, I know I overuse that word, but I think there's an epidemic of depression in our communities, probably disproportionately affecting black women as more and more black men go to prison and stuff like that. So I think we have much more capital, we have much more assets than we are using because depression steals energy and it steals innovation. WHO projects that by 2030, depressive disorders alone would be the leading cause of disability in this country, and in the world, in the world. So we're disproportionately affected by it. And that becomes very interesting as we observe, the people who come back from Iraq and Afghanistan are predisposed to post-traumatic stress disorder. And then you try to figure out, well, how does the distress that people live with every day in this country, in certain communities, the fear, the lack of safety, how does that affect productivity and capital? So I think the mental health problem not just affect whether or not we're able to control depression, diabetes, for example. We've focused really a lot recently on, with this epidemic of obesity, are we going to be able to control this diabetes? And the fact of the matter is that if a person is struggling with depression, it's unlikely that you're going to control their diabetes. It's unlikely they're going to be able to cooperate with a program of control. So I don't think enough can be said, and I know even though I released that report with your help, I don't think enough can be said about the impact that mental health problems are having on all of these other problems and on the extent to which we're using this asset that we've been talking about that we have. So we need much more attention to it, and we need to start early to deal with the kind of environments. For example, the study that Harvard School of Public Health did on the streets of Chicago, showing that these kids between the ages of 3 and 5 who witnessed violence like murder were twice as likely to be victims of perpetrators of the same kind of violence before they were adults. Think about the implications of that. And Tom Insel, who's head of the National Institute of Mental Health, talks a lot about the implications for the development of the brain and how experiences in childhood affects that. So we have a great potential there, much greater than we're taking advantage of in terms of this asset, because we're not intervening to improve community mental health. I guess that's the best way to say it. Community mental health leads to individual mental health, and we've got to deal with community mental health.
Thank you very much.